Imagine taking a high-speed drill, right, to a piece of bone the size of a grain of rice.
Yeah,
and you're carving this microscopic socket into it and then balancing it on a tiny trampoline. All while, and this is the crazy part, your patient's head is tilted sideways and you just have to guess what gravity will do to that entire structure the moment they stand up.
It is honestly wild when you frame it like that.
Because usually, when we talk about a medical diagnosis, there's this expectation of clean precision. Like, you break your arm, the x-ray shows a jagged white line and it's a binary issue. It's broken or it's not broken.
Exactly.
But when you look at the mechanics of hearing loss, especially when the actual physical plumbing of the ear breaks down, it is just a completely different landscape.
Oh, it is the absolute definition of diagnostic and surgical muddy waters. I mean, we usually associate hearing loss with nerve damage, right? Those delicate hair cells in the inner ear getting permanently fried from years of loud concerts.
Guilty as charged, yeah.
Right, but what we are analyzing today is conductive hearing loss, which is entirely mechanical. It is a physical restriction of sound wave energy that's just trying to displace the basilar membrane.
Welcome to the deep dive, everyone. I'm your host, and today we are unpacking this absolute marvel of microengineering that surgeons use to rebuild the tiny bones inside your skull.
And I'm your expert guide for this deep dive.
Yeah.
The procedure we're looking at is known as ossicular chain reconstruction, or OCR, if you're reading the textbook chapter we're sourcing this from.
Yeah, our mission today is to explore how specialists solve these microscopic hardware failures. Because honestly, the physics of restoring human hearing are staggeringly complex.
They really are.
And to understand the solutions, we have to isolate the problem first. So conductive hearing loss basically means the mechanical energy transfer is blocked, right? Before it ever even reaches the nerves.
That's spot on. The mechanical blockade can happen in several ways. The ossicular chain, which is the malleus, ammucus, and stapes, might be fixed in place, or eroded away, dislocated, or even fractured. The end result is just that the vibratory energy simply cannot reach the fluid of the inner ear to trigger the nervous system.
But before we even get to broken bones, there is this fascinating clinical anomaly in our source material regarding the fluid dynamics of the inner ear. It's known as the third window effect, or dehiscence of the superior semicircular canal.
Yeah, this is a perfect example of how bizarre the physics of hearing can actually be.
Right.
So the inner ear typically utilizes two windows, quote unquote, to handle the fluid wave that's created by sound vibrations.
Okay.
But in this condition, a structural gap, the dehiscence, opens up in the bone of the superior semicircular canal, and it creates a literal third window.
Which introduces a huge variable into the hydraulic system, because, fluid will universally take the path of least resistance.
Exactly.
So the energy of the sound wave just expands outward through this new third window, instead of traveling along its intended path through the cochlea to stimulate the hearing nerves.
And the clinical presentation of this hydraulic leak is what makes it so deceptive for doctors.
How so?
Well, a patient can present with significant conductive hearing loss, meaning the sound energy isn't reaching the nerves, yet their acoustic reflexes might still be perfectly intact.
Wait, really?
Yeah, those muscle contractions in the middle ear that trigger in response to loud noises, they still fire perfectly.
Oh wow, so the mechanical bridge of bones is actually working fine, but the fluid dynamics underneath are just totally short-circuiting the system.
Precisely. It's a hydraulic failure, not a hardware failure.
That is wild. But okay, if we pivot from the weird fluid dynamics to the actual hardware, like the bones themselves being eroded or fused, how do surgeons even begin to approach a repair? Because, if I'm going to fix a complex engine, the very first thing I need is a schematic, right? I need to understand what parts are broken and what parts I can salvage.
Yeah, and surgical pioneers realized the exact same thing back in the 1950s. They needed standardized language to map the middle ear, which is what led to the Wolstein classification system.
Right, I saw that in the text.
Yeah, so Wolstein created types I through V, and he based these categories on a very specific criterion, the most lateral intact structure that still remained connected to the inner ear.
Okay, wait, I want to challenge the logic of what happened next in the history, because the clinical standard eventually shifted away from Wolstein, right? And moved toward Farrier's classification.
Yes.
But Wolstein's system sounds perfectly logical to me. If you're going into a surgical zone, you need to map out the salvageable parts. So why scrap a system that makes total anatomical sense for assessing the damage?
Well, what's fascinating here is that it makes sense for the assessment, sure, but it completely fails at describing the solution.
Oh, interesting.
Yeah, Farrier recognized that classifying a surgical site based solely on the leftovers you started with, it doesn't give the next doctor any useful information about how the ear currently functions.
Ah, okay.
So he shifted the entire paradigm. He based the classification on the pathologic anatomy at the completion of the surgery.
Ah, I see the distinction now. It's basically the difference between looking at an architectural salvage list versus looking at a finished as-built blueprint.
Precisely. Under Farrier's system, a type 3 reconstruction means continuity has been established from the stapes to the malleus, or the eardrum, by interposing some material.
Right.
And type 5V denotes a reconstruction that starts all the way down at a mobile stapes footplate.
Okay.
So it tells anyone looking at that patient's chart exactly what the structural reality of that middle ear is right now, rather than just listing the debris the previous surgeon happened to find.
So if Farrier's system maps the final architecture, what are we actually using to build these bridges? Because we are talking about spanning a gap in a space that is literally smaller than a dime.
This is where surgeons deploy highly specialized prostheses, and they're primarily categorized into two acronyms that you'll see in the text, PRP and the TOR.
Let me guess the naming convention here. P for partial, T for total?
Spot on, yeah. A partial ossicular replacement prosthesis, or PRP, is utilized when the top part of the stapes, the superstructure, is still present and functioning.
Got it.
So the surgeon only needs to bridge a partial gap between that existing superstructure and the eardrum.
And conversely, I imagine the total ossicular replacement prosthesis is deployed when that superstructure is completely destroyed.
Exactly.
So the surgeon only has the flat vibrating base of the stapes, the footplate, left to work with. They have to build a total bridge from that flat base all the way out.
Which requires an entirely different approach to stabilization and balance, as you can imagine.
Oh, for sure.
But before surgeons even reach for a synthetic titanium implant, one of the most remarkable techniques they use doesn't involve synthetics at all.
Wait, really?
Yeah, it relies on the patient's own biological material through an autograft technique called an incus interposition.
The microcarpentry involved in this is staggering to me. Like, the incus is frequently the bone that gets eroded by disease, right?
Yes, very common.
And the text says surgeons will actually extract the patient's damaged incus, completely remove it from the ear, and use a microscopic high-speed drill to manually sculpt it.
They do.
They just turn the patient's own diseased bone into a custom-fitted connecting beam and then place it right back into the middle ear. That is insane.
It is an incredibly delicate art form.
Yeah.
And it's performed entirely while looking through a binocular microscope.
I can't even imagine.
The geometric sculpting required to make this work is incredibly unforgiving, because to make the sculpted incus fit securely onto the tiny rounded head of the stapes, the surgeon must drill an acetabulum.
Which is essentially a microscopic ball and socket joint, right?
Basically, yeah.
They carve a tiny cup into the short process of the incus so it locks perfectly onto the stapes. And then on the other side of that same tiny bone, they have to drill a customized groove meant to lock onto the handle of the malleus.
And they have to do all of this while calculating a really complex spatial geometry.
What do you mean?
Well, the stapes and the malleus rarely line up perfectly on a vertical axis.
Oh, true.
If the malleus is located anterior to the stapes, meaning it sits further forward in the ear canal, the surgeon cannot just carve a straight vertical pillar.
They have to sculpt the bone to account for for both the vertical height needed to bridge the gap and the horizontal span required to reach the malleus.
Exactly.
It's like designing a specialized angled support column for a suspension bridge, but you are doing it on a piece of bone so small that a single slip of the drill would completely obliterate it.
That's a perfect analogy. There are absolute limits to autografts, though. Sometimes the native bone is just too severely eroded, or it's been infiltrated by cholesteatoma.
Right.
Which is essentially an abnormal expanding skin cyst in the middle ear that secretes enzymes that actively destroy bone.
Yikes.
Yeah, if that disease is present, you simply cannot safely reuse the bone. That is when the high-tech synthetic alternatives step in.
Enter the synthetic cyborg components.
Yep.
The primary materials mentioned in our source are dense hydroxyapatite, which is a mineral naturally found in human teeth and bones, and adjustable titanium. And there's this brilliant structural physics problem regarding how these different materials interact with the eardrum.
Oh, absolutely. The interface between the prosthesis and the tympanic membrane is critical.
Right. If a surgeon uses a prosthesis with a titanium head, they absolutely cannot let that metal touch the eardrum directly.
No, never.
Because of the constant rapid vibration of sound, the metal will eventually just wear a hole right through the delicate tissue.
Yeah, it's too abrasive.
So they have to harvest a piece of the patient's own cartilage and place it between the titanium and the eardrum as a buffer.
It distributes the mechanical stress.
Exactly. It made me think of like setting down a heavily sweating ice cold glass on a soft wooden table.
Oh, yeah.
You absolutely need a coaster or you will ruin the surface. That is the titanium needing the cartilage buffer.
Yeah.
But if the surgeon uses a prosthesis topped with hydroxyapatite, they don't need the cartilage at all.
Right, because hydroxyapatite is highly biocompatible. It allows for osseointegration.
Meaning the bone grows into it.
Basically, yes. The body's tissues will naturally adhere to it without treating it as a foreign abrasive object.
So it's like putting that same sweating glass on a dense granite countertop. You don't need a coaster.
That's exactly it. The material science entirely dictates the surgical approach. And, if the erosion is truly microscopic, surgeons have tools for that too.
Like what?
Well, what if only the incustostapedial joint, the tiny microscopic connection between the incus and the stapes, is eroded?
Oh, I see. Just a tiny part.
Yeah, that specific joint has one of the most tenuous blood supplies in the human body, making it highly susceptible to necrosis. So in those cases, surgeons want to avoid removing the entire bone if possible.
Okay, so what's the fix?
They might use an apple bomb prosthesis, which is designed to just clip on and bridge that specific microscopic gap, or they might even use hydroxyapatite bone cement to literally glue the eroded joint back together.
That is incredible. But getting all these parts, whether it's bone cement, titanium, or a sculpted autograft, getting them into the ear is only half the battle. The true artistry, and honestly the most terrifying part of this from a physics perspective, is how these tiny components behave once the patient wakes up. This brings us to the tenting principle.
Ah, yes. Key operative learning point number 6 in our source.
Right.
For any reconstructed ossicular chain to effectively transmit sound waves, the prosthesis must be placed under very slight, highly calculated tension.
Okay.
It cannot merely rest against the eardrum. It actually needs to push up against it slightly, creating a minimal tenting effect over the head of the prosthesis.
But the margins for error there just seem physically impossible to gauge.
They are razor thin.
Because if a prosthesis is cut even a fraction of a millimeter too short, it lacks that tension, and it will eventually just tip over or become displaced inside the middle ear.
Right.
But it's cut a fraction too long, the tension is too high, and the constant pressure will cause the prosthesis to slowly push its way completely out of the ear, literally extruding right through the eardrum.
It's a real risk, yeah.
So how in the world does a surgeon find that exact Goldilocks tension?
Well, they utilize microscopic sizing sets to measure the gap, but they're also fighting a massive, invisible, variable gravity.
The gravity dilemma. When you think about the vectors involved here, it's wild.
It really is. The surgical procedure is performed with the patient lying supine, so flat on their back, with their head turned, so the affected ear faces directly up toward the operating room ceiling.
Right.
In this position, the eardrum is essentially horizontal, but human beings spend the vast majority of their lives upright.
Right, so the surgeon has to build this microscopic tension-loaded suspension bridge while the patient is horizontal.
Yes.
And they have to anticipate exactly how the angle and tension of that prosthesis will shift when the patient stands up, the eardrum becomes vertical, and gravity pulls the entire assembly in a completely different direction.
And compounding that gravitational challenge is the clearance issue. A prosthesis must remain entirely free-floating.
Meaning it can't touch the sides.
Exactly. It cannot touch the surrounding tympanic ring, and it cannot rest against the cochlear promontory, which is the bony wall of the inner ear.
Because if it touches the surrounding bone, the acoustic vibration is instantly dampened.
Right.
It's like trying to ring a handbell, but instead of holding it by the handle, you grab the actual bell tight in your fist.
Yes, perfect.
You strike it and you just get a dull thud. The energy is absorbed by your hand instead of vibrating the air. The ossicular chain has to only touch the eardrum on one side and the inner ear window on the other.
Which presents a severe mechanical problem during the surgery itself.
Right, because if a total ossicular replacement prosthesis has to be completely free-floating, and you just balance a top-heavy titanium shaft on a flat, slippery footplate.
Yeah, how do you prevent it from immediately falling over before the ear has a chance to heal and form stabilizing scar tissue?
Because you can't exactly go in there with a microscopic screwdriver and bolt it to the bone.
No, absolutely not.
Yeah.
You rely on temporary dissolving architecture.
How does that work?
Surgeons often pack wet gel foam, which is an absorbable gelatin sponge around the base of the titanium shaft.
Oh, clever.
Yeah, this holds the prosthesis perfectly plumb during the immediate postoperative period. And then, over the subsequent weeks, as the body heals and the tympanic membrane firmly attaches to the top of the prosthesis.
The gel foam just goes away.
Exactly. It simply dissolves away, leaving the prosthesis perfectly suspended in the middle ear space.
Wow. It's temporary scaffolding that removes itself once the concrete is dry.
That's a great way to put it.
But what happens when the biological environment of the ear itself is just overtly hostile to all of this engineering?
This brings us to a severe complication called tympanosclerosis, and this completely alters the surgical timeline.
We are talking about calcification here, right?
Yes. In response to recurrent ear infections or chronic inflammation, the body can actually deposit a sclerotic plaque.
Oh.
It's a dense calcification that essentially cements the delicate ossicles in place, turning a highly mobile suspension bridge into a rigid block of stone.
And the standard protocol here introduces a major staging issue.
It does.
Because if a surgeon opens an ear and finds the stapes footplate completely fixed by this calcified plaque, and the patient also has a perforated eardrum, they will not attempt to fix both problems during the same operation.
No, they won't. That is a fundamental safety boundary.
Why is that?
You have to consider the anatomy. The inner ear vestibule, which is located immediately behind that fixed footplate, is a sterile environment, and it's intimately connected to the cerebrospinal fluid.
Okay.
A perforated eardrum, however, means the middle ear is exposed to the outside world and is highly likely to be contaminated with bacteria.
Ah. So if you drill open that fixed footplate to place a prosthesis while the eardrum is still open, you are creating a direct superhighway for bacteria to travel from the outside air directly into the brain's sterile fluid system.
Precisely. You risk profound deafness or worse, meningitis.
So therefore, the procedure must be staged.
Right.
The surgeon patches the eardrum and closes the ear. Then they force the patient to wait 4 to 6 months for that drum to fully heal and recreate a sterile, closed environment in the middle ear.
And only then will they go back in to rebuild the bone structure.
Man, that requires immense patience from both the surgeon and the patient.
Oh, absolutely.
And exploring all of these hostile environments from, bone-eating cysts to calcified plaques, it really leads us to the ultimate evidence-based reality check regarding this entire field of surgery.
It does.
Because we have detailed all these incredible tools today. Adjustable titanium shafts, hydroxyapatite mushroom caps, meticulously sculpted autografts, and the razor-thin margins of tenting tension.
Yeah, it's a lot of tech.
But out of all of that advanced engineering, what actually determines if the patient will hear again?
Well, when you look at the clinical data, specifically there's this major study by Demir et al. Analyzing over 100 of these procedures, you find a pretty humbling conclusion.
Let's hear it.
The functional outcome of the surgery, the actual restoration of hearing, is highly correlated with the pathophysiologic status of the middle ear disease itself.
Okay.
It does not depend on the type of replacement material or the specific surgical technique used.
Wow. Let's break down exactly what that implies, because it doesn't matter if you utilize the most expensive, highly engineered titanium prosthesis on the market,
Nope.
or if you spent 3 hours hand sculpting the patient's own incocus with a diamond burr. If the mucosal lining of the middle ear remains chronically inflamed, or if the eustachian tube fails to ventilate the space properly, causing fluid to continually build up, the mechanics will fail.
Exactly. The biological environment will overpower the engineering every single time.
So the underlying health of the ear dictates the success of the hardware.
Always.
We've covered incredible ground today. We started by reframing conductive hearing loss as a mechanical blockade, right?
Yeah.
Exploring how a bizarre third window can leak hydraulic pressure and cause deafness even when the acoustic reflexes fire perfectly.
And we examined the architectural blueprints of Wolstein and Ferrier, understanding why modern surgeons classify the surgical site based on the final functioning anatomy they built, rather than the damaged salvage they started with.
Right. We looked at the extreme microcarpentry of carving sockets into bones the size of rice grains, the necessity of cartilage coasters for titanium implants, and the high-stakes 3D chess match against gravity and tension.
And finally, we confronted the reality of tympanosclerosis, highlighting that even the most brilliant microengineering is ultimately at the mercy of the biological environment it is placed within.
So to you listening, the next time your ear feels a little plugged or you hear about someone undergoing middle ear surgery, I want you to picture what is actually occurring in that space.
It's remarkable.
Picture that
If the ultimate success of this staggeringly precise microengineering relies entirely on the pathophysiologic health of the surrounding tissue, it really makes you view all medical technology through a different lens.
How so?
Well, how often do we obsess over engineering the perfect artificial seed-like, a flawless titanium joint, a highly calibrated pacemaker, or a neural implant, only to forget that the soil of the human body is what truly decides if that technology will ever take root?
Seed and soil, that is an incredible lens to view the future of medicine through. Thank you for joining us on this deep dive.